Hi, everyone. Welcome to the latest in myelofibrosis treatments. What clinical trials are available to me? This is being hosted by the Leukemia and Lymphoma Society and the Patient Story. So just a quick introduction. My name is Stephanie Trong. I am the founder of the Patient Story. And more importantly, I also got a blood cancer diagnosis before. Now, mine was in non-Hodgkin lymphoma, but I think that there are so many shared experiences in what we're all looking for, and that is what the Patient Story is all about. We try to help navigate both patients and their supporters, their caregivers, care partners after a diagnosis. And we do this through in-depth conversations with patients, care partners, top specialists across different cancers like the ones you'll hear from today. And it's especially important to have these educational programs specifically for us when it comes to topics like clinical trials, really daunting and overwhelming jargon. And so we're trying to humanize what your options are. We're so proud to be co-hosting this with the Leukemia and Lymphoma Society, which I'm sure many of you are already familiar with. It's the world's largest nonprofit health organization dedicated to funding blood cancer research, which of course saves lives, as well as offers patient services and education. There are great resources if you haven't checked them out yet, like their information specialists who are just a phone call away to help you answer some questions. And a favorite of mine and of ours, highlighting the LLS's Clinical Trial Support Center. It is a very critical resource for free that offers one-on-one support to enroll in and stay in clinical trials. So we'll be bringing up their contact information throughout this program as we share what we're calling our trial knowledge tidbits. We also want to say special thanks to GSK for supporting our educational program, which really helps us make these available and free for our audience. The LLS and the Patient Story retain full editorial control, though, of the entire program. And reminder, this is not meant to be a substitute for medical advice. We want you to be able to walk away to ask your own doctors and medical teams questions about clinical trials in myelofibrosis, but it is not a substitute. And lastly, we want your feedback on whether this program was helpful and what topics would be so important for us to cover for you in the future. So please fill out our survey. It's going to pop up automatically when this program ends, and that will automatically enter you into a raffle for a couple of our $50 Amazon gift cards. Okay, now to the good stuff. I'm really thrilled to introduce someone who's not only a big MPN and myelofibrosis patient voice and leader in the community, but also someone I'm lucky to call a friend now, Ruth, who will be leading the conversation from this point forward. So Ruth, I know that you're going to share more about your own myelofibrosis cancer story in just a bit and how you really became such a passionate advocate. But first, can you share a little bit more about yourself outside the cancer context? Because as we know, we are so much more than a diagnosis.
Thanks so much, Stephanie, and great to see you all. So professionally, I'm a health and science writer who now writes primarily about cancers, in particular blood cancers. I also host patient programs like this one, and I have the privilege of speaking to so many of the world's most prominent researchers and clinicians, like today's experts, who I'll move right along to introduce. Dr. Ruben Mesa is a renowned hematologist-oncologist. He's currently the president of Atrium Health Levine Cancer Institute and senior vice president of Atrium Health. He's also the executive director of the NCI-designated Wake Forest Baptist Comprehensive Cancer Center and the vice dean for cancer programs at Wake Forest School of Medicine. He's globally recognized as a leader in the MPN space, and we are so fortunate to have him with us today. So just very quickly, our audience would love to know you beyond that white coat of yours. What drew you to work in cancer and research?
Well, cancer is just such a terrible disease. It really impacts and steals from individuals, length of life and quality of life. I myself have been touched by cancer as so many have, and everyone really on this video. My father passed from cancer. My mother's a cancer survivor. And I was able to witness through that, the impact that the cancer research, developing new therapies, as well as the value of really compassionate care, how important all of these things were. So in many ways, cancer, I think, has attracted many of us because we can feel we can make a real difference in a difficult disease. And it's also an exciting time where scientific progress is really, I think, making a genuine impact.
And you are making a personal impact, all of you. So, Dr. Angela Fleischman is a hematologist oncologist at UC Irvine Health, where she leads the Fleischman Lab with a special focus on MPNs and improving the options and care for patients. On that note, as a physician scientist, Dr. Fleischman not only treats patients, but also actively researches hematological malignancies. She's passionate about translating findings from the lab bench to the patient's bedside. Dr. Fleischman, we'd love to know a little more about your passions as well. What drew you to blood cancers and research?
Well, thanks for this opportunity to speak today. So I have always been extremely interested in blood cell development. I started out as a PhD student prior to my MD and focused on normal blood cell development, what determines whether a blood stem cell goes to one direction or the other. And then when I decided to go to medical school, when I first learned about myeloproliferative neoplasms, I was just extremely fascinated by them because I felt that it was an opportunity for us to really learn a lot about both normal as well as what happens when blood cell development goes awry. And another extremely interesting aspect of myeloproliferative neoplasm that I was extremely drawn to is the ability to really make connections with patients throughout the years because it's a chronic disease. And as a physician, I'm able to travel with them through their journey as a patient. So there's many aspects of myeloproliferative neoplasm that I find extremely rewarding to take part in.
Thank you. And we'll get into some of those details as we move along. Finally, I'd like to introduce Melissa Melendez, who's a nurse navigator with the Leukemia and Lymphoma Society's Clinical Trial Support Center. Melissa, what drew you to becoming a nurse and to the important work that you do?
Thank you, Ruth. I've been in the oncology field for almost 20 years, and it was really a happy accident how it happened. I started my first clinical rotation in nursing school, and I was placed on the oncology unit. And instantly, I fell in love with not only helping patients on their journeys throughout their treatment, but I also got the privilege to care for their families that were experiencing the cancer diagnosis as well. I decided that oncology was my passion and that it was going to be my career path, and I'm currently a nurse practitioner. And working for the Leukemia and Lymphoma Society in the Clinical Trial Support Center has been such a blessing for me as a nurse, and it was a pretty easy transition from my previous occupation. I help patients with clinical trials and help them throughout their journey so they can make informed decisions about their care. I get to build relationships with patients and family members that last for years.
Thank you to all three of you. It's nice to hear a little bit about each of you. So, what is myelofibrosis, which is what we're here to talk about today, right? Myelofibrosis is one of the MPNs, a myeloproliferative neoplasm, and a very personal topic for me. I've lived with an MPN for nearly 30 years, originally diagnosed with essential thrombocythemia or ET at age 38 while I was raising two young boys. When an aspirin a day was stopped because I developed an ulcer, I ended up with clots in my portal and splenic veins. After a week in the hospital, I was then put on an anticoagulant or a blood thinner. So several years later, my bone marrow flipped a proverbial switch, and instead of producing too many platelets, it now produced too many red blood cells. The diagnosis was changed to polycythemia vera. And I lived with periodic phlebotomies and daily hydroxyurea. And that was just a part of my life, as it is to many people who live with polycythemia vera and the different MPNs. So fast forward to 2018 when I had surgery for early colon cancer, and the surgeon was very focused on avoiding any more clots. So instead, I had the opposite happen, and that was a major bleeding episode that put me in the ICU for nearly a week, followed by several months of healing. It was then that I finally sought out an MPN specialist. I began to see Dr. Ellen Ritchie. She's at Weill Cornell in New York, where I had an updated bone marrow biopsy and confirmed diagnosis of myelofibrosis. So I used to say it was mostly asymptomatic, but in fact, I've lived with severe migraines, a few TIAs, and other constitutional symptoms my whole life. It wasn't until I was taken off hydroxyurea before starting a clinical trial that I realized just how severe my symptoms were without treatment. I had had both life-threatening clots and bleeding episodes, and now I had such extreme fatigue that I couldn't walk up the street without stopping to lean or to sit on a neighbor's step. Of course, I also know how fortunate I am, as many people suffer so much more than I ever have with any of these diseases, with some of these chronic blood conditions. Um, but in particular, we're talking today about myelofibrosis. So, with that, um, let's just dig right in. And Dr. Fleischman, exactly what is myelofibrosis?
Okay, so the word myelofibrosis, people may interpret that as having some fibrosis in the bone marrow. What we're talking about today is the myeloproliferative neoplasm myelofibrosis, which also can have some fibrosis in the bone marrow, but want to emphasize that fibrosis in the bone marrow does not always equal myelofibrosis. With the MPN myelofibrosis, it's a chronic blood cancer which stems from the proliferation of some abnormal mutant cells in the bone marrow. Exactly what causes the fibrosis in the MPN myelofibrosis is unclear. The abnormal megakaryocytes, or those are the cells that are producing platelets, have been implicated as the sort of the bad cells in myelofibrosis and causing the fibrosis. Part of myelofibrosis is not only the fibrosis in the bone marrow, but patients tend to also have an enlarged spleen, which can also be seen in ET and PV, but is more prevalent in myelofibrosis. Also, patients with myelofibrosis, their blood counts can look very different in terms of there's a wide variety of what a myelofibrosis patient's blood counts look like, but a classic myelofibrosis patient may have some anemia. They may have a little bit of a high white blood cell count. They may also have some cells that are called immature cells in their blood. So their bone marrow cells are not maturing fully before they go into the blood, just indicating that there's some stress going on in the bone marrow. And also myelofibrosis patients can have some significant constitutional symptoms. ET and PV can also, but in myelofibrosis, they tend to be more severe. But I do want to emphasize that just because somebody has a bone marrow biopsy that says fibrosis does not necessarily always equal the MPN myelofibrosis. Other things like autoimmune diseases can cause some fibrosis in the marrow. Infections can cause fibrosis in the marrow. Other blood cancers can cause fibrosis in the marrow. So what I want to emphasize is fibrosis does not always equal the word MPN myelofibrosis.
That's a really good reminder and not something that people focus on much. So thank you for that. The world of MPNs, as we know, in particular myelofibrosis, is changing before our eyes, right? As clinicians, researchers, and people living with these conditions. Dr. Messer, would you tell us how the landscape of treatments for MF patients has changed so dramatically just in the last 2 to 3 years?
Well, thank you so much, Ruth. So, during my career, I saw patients with myelofibrosis first in the beginning of my training, now almost 30 years ago. In the first half of those 30 years, the medicines we had for myelofibrosis were really limited because we had a very limited understanding of the biology of the disease. What happened about 15 years ago is that we identified important genetic changes, such as the JAK2, calreticulin, MPL, and others, that are important changes in genes that lead downstream to a patient having a myeloproliferative neoplasm. And with that, we've really seen an explosion in many different types of therapies that have been tried to really make an impact. Over the last 3 years, we've seen a rapid increase, really first in FDA-approved options that we're going to go into in a moment, which are now 4 different drugs that are inhibitors of the JAK2. And they've made a real impact for patients with myelofibrosis regarding enlargement of the spleen, symptoms, perhaps helping to slow down the course of the disease to some degree, and some individuals even really dramatically so. And then the next step, which we're really launching into, are now combinations of therapies where we use more than one drug, sometimes looking at treating different aspects of the disease or different targets in terms of the biology of the disease to make a deeper impact. Indeed, as wearing my cancer center hat, as I look at how therapies are advancing in many different diseases, both blood cancers, as well as non-blood cancers, most of the time we're now using more than one therapy in ways that these medicines complement each other to treat the disease. Different blood disease such as multiple myeloma, now they're using up to 4 different drugs at a time to try to treat these diseases. So the explosion has been, we went from really very little understanding to now multiple drugs, a much greater understanding of the biology of the disease, and hopefully deeper and deeper impact.
Right. Dr. Messer, we're going to get to specifics about what clinical trials are available to patients today. But first, what is the standard first-line treatment been for myelofibrosis?
Well, when patients come in with a diagnosis of myelofibrosis, their doctor first gets a sense in terms of the risk of the disease, how likely is the disease to be life-threatening, as well as the burden that the patient is facing from enlarged spleen or from symptoms or from risk of progression. A discussion is had whether we should pursue the potentially curative option of bone marrow transplantation or stem cell transplantation. We use those terms interchangeably. Now, that's a very complex therapy, but it's something that we consider really kind of throughout for individuals up until their 70s, depending upon the risk of the disease and others. For the majority of individuals, based on a variety of factors, probably over 90%, we start with medicines. So the current standard approved medicines, the only approved medicines in myelofibrosis, are the JAK inhibitors. So that's a bit of really the starting place. Transplant, either in the near future, delayed, or we're not going to pursue transplant, and then consideration of a JAK inhibitor.
And as you mentioned, we currently have 4 FDA-approved JAK inhibitors, now with momelotinib that was approved September 15th. First, how do JAK inhibitors work? If you could talk us through that quickly. And then for each of the approved JAK inhibitors, would you explain a little about what their benefits and their limitations are?
So first, in myelofibrosis, there are 3 main mutations that we believe are involved with causing the disease. The JAK2 or the JAK2 V617F, the mutation in calreticulin, and mutation in MPL. And there's even a small subset of people who do not have one of those 3. All of those mutations lead to the same outcome. And the same outcome is an overactivation of the protein JAK2. JAK2 is one step. It's like an on-off switch stuck in the on position, telling cells to grow. The JAK inhibitors are all medicines that really help to decrease that activation of JAK2. So regardless of which of those mutations a patient has, or even if they don't have one of those 3 mutations, they all seem to benefit from JAK inhibitors. So they all really help to turn that protein off, JAK2. Now with that, there are 4 approved medicines. Ruxolitinib, or Jakafi, it's been approved since about 2011. It improves spleen and symptoms. It certainly may help patients who respond live longer with the disease. And in many ways has long been the standard, as well as it's frequently been used as the base in combination trials. The second is fedratinib, or Inrebec. This has been approved since 2019. It can be used, again, to improve spleen or symptoms. It may be used in the frontline setting instead of ruxolitinib, or in the second-line setting of someone that has had ruxolitinib already. The third drug is pacritinib, or Vonjo. This was approved in 2022, and this one has a little distinct profile. It's particularly helpful for decreasing spleen and symptoms, but for individuals that have a very low platelet count. Both ruxolitinib and fedratinib are approved for individuals with a platelet count above 50,000. Pacritinib, we know, can be helpful in anyone, but its particular unique niche is in individuals under 50,000, and we certainly will consider it under 100,000 for individuals that have lower blood counts. And the most recently approved in September 2023 is momelotinib. This can improve spleen symptoms and anemia. And it's the strongest improvement in anemia of the other 3, Pacritinib sometimes can have improvement in anemia. Unfortunately, both fedratinib and ruxolitinib sometimes can have anemia as a side effect or worsen anemia, and rarely would improve anemia. So some differentiation between the four of them, but they all overlap in many ways in terms of improving spleen and symptoms, and can be beneficial regardless of the mutation profile that a patient with myelofibrosis has.
It's so very exciting for the MPN community to finally have so many treatment options. And I think something that you touched on that maybe we'll get to later is a question people often think, because they have other mutations other than the JAK2, that perhaps a JAK inhibitor won't help them. So thanks for noting that that's not necessarily the case. So Dr. Fleischman, here's the loaded question, right? Now, how do you know which JAK inhibitor might or might not work and which one to try first?
So this is an evolving topic, which is, I would say, really exciting that now we have 4 different JAK inhibitors, so we can try to tailor the best JAK inhibitor for the person up front. One have to say that it sometimes does take a little hit or miss trials. But as Dr. Misa just described, each JAK inhibitor has a little bit of a different profile. All of the JAK inhibitors do inhibit JAK2, but each one has, I guess you could say, off-target effects of inhibiting different JAKs and some different proteins. And that may explain why they have a little bit of each their own unique profile. So each myelofibrosis patient is quite unique, and so they have different needs. For example, somebody who has an enlarged spleen, symptoms, and also has some pretty robust blood counts that maybe you want to bring down the blood counts, then ruxolitinib or Jakafi would be a great option for that. That's the only JAK inhibitor that is also currently approved for PV, in which the purpose is to bring down the blood counts. If the person's primary problem is anemia, which is unfortunately a very common problem in myelofibrosis, then it's very exciting that just very recently, now we have an option that's specifically designed for patients with anemia. As Dr. Mesa had described, the specific niche of the platelets less than 50, that's a patient population that's very, very appropriate to start pacritinib or Vonjo first. The question comes because many patients with anemia also have a low platelet count. So what to do in somebody who has both anemia and a very low platelet count, say below 50, then I think that we're going to have to learn how to sequence and how to, make decisions, pacritinib versus momelotinib. But at the present time, for a myelofibrosis patient that has both anemia as well as thrombocytopenia, low platelet count, the two options exist up front, could be momelotinib or pacritinib at this point in time.
Yeah, that's a great summary. Thank you. So, Melissa, I think this is where clinical trials come in, right? Trying to see if we can improve standard of care and give more and better options to more people. But before we dive into specific clinical trials, let's set the stage to humanize these studies with what we're calling our first trial knowledge. There are different phases of a clinical trial, and let's start with what they are and what do they mean.
Yes, I like to think of clinical trials as steps to drug approval. So all drugs must move through the steps or phases to ultimately be approved by the FDA. And if drugs are studied in new combinations or in diseases outside of their approved indication, they still must need to go through all the phases. For phase 1 trials, treatment is tested in a very small number of patients. It could range from 20 to 40 patients, and we're really looking at the safety of a drug as well as the side effects, and we are testing dosage. Phase 2 trials typically build on phase 1 results, and they're trying to determine the effectiveness and safety of the drug in a specific population. So we're really trying to answer the questions, does the treatment work and how well does it work? Phase 3 trials are often referred to as randomized trials, so it's comparing a new treatment against the best standard treatment. And these trials can be done in anywhere from 300 to 3,000 participants. Researchers are trying to see if a new treatment has better survival outcomes and less side effects. When a trial is completed that shows that the drug is in fact better than standard of care or the best standard treatment, that's when the newly investigated drug now becomes a standard of care and will become FDA approved. I wanted to briefly mention there are phase 4 trials, but by the time a clinical trial enters phase 4, the FDA has already approved the treatment. So these trials are done in thousands of patients and they usually go on for many years.
Okay, Melissa, so let's do one more trial knowledge at this point, and this one needs myth busting. We hear a lot from patients and care partners that I wouldn't want to risk getting a placebo. So are placebos used in myelofibrosis clinical trials, or is every trial participant always receiving at least the standard of care?
Ruth, I'm really glad you asked that because federal regulations require patients to know if a placebo, which is an inactive substance that looks the same as the one used as treatment, will be incorporated into a trial. An example of a placebo could be a sugar pill. And placebos are not typically used with patients in cancer clinical trials. But if a placebo is used, the person will also receive the standard treatment for their specific cancer. So, in our case, myelofibrosis patients. The placebo will be in combination with active drugs. So, patients are receiving at least the standard of care. So, no one with active cancer would be treated by only a placebo because that is unethical. When researchers do use a placebo, they must either tell the patient that they have a chance of getting a placebo, and they have to tell the patient that they will receive an experimental treatment at some point in the clinical trial, if not right away. For example, you may be assigned to the placebo group, but if your cancer gets worse, researchers will switch you to a study drug or new treatment.
So some of the most exciting clinical trials for MF patients are for combination therapies, which you touched on a little bit earlier. We'll talk about specific trials in a minute, but Dr. Mesa, can you explain what the idea is behind these combination drug approaches and who might benefit?
So one, as we think about different populations of patients, we have those who are JAK inhibitor naive. So what does that mean? Individuals that have not had a JAK inhibitor yet. This may be at the time of diagnosis. This may well be for individuals who have had the disease for a while, but have been observed, and now their doctors feel based on spleen symptoms or changes that they need to begin on a therapy. There are individuals that have been on a JAK inhibitor, ruxolitinib, or perhaps one of the other agents, and have had some benefit, but we feel that there's opportunity for further benefit. And some of these individuals are participating now what we call add-on studies, where you have a JAK inhibitor, they've been on for a while, they have a partial response, and you add a second drug. And then third, an individual, they were on a JAK inhibitor and now no longer have a benefit for that medication, and then you are switching them to a different therapy altogether. So different tiers of needs, and important as we talk about individual clinical trials.
Let's talk about some of those combination trials. So there are a number of them where JAK inhibitors are given with the addition of a novel new agent with a different mechanism action, which is sort of a fancy way to say that they work differently, right? Let's talk about selinexor. Can we start there? Selinexor plus JAK inhibitor.
So you can think that there's a whole constellation of different agents that are having an impact potentially in different mechanisms of action that are being looked at in combination with JAK inhibitors. This is one that's a little bit earlier on in its development. It's an approved drug in the area of multiple myeloma, and has been approved since July of 2019. Its trade name is Expovivo. And this, again, it's an anti-cancer medication. Its mechanism of action is it's a selective inhibitor of nuclear export. So again, is working on some of the processes kind of within the cell in a different way that we feel may be beneficial in combination. It, like many of these studies, are ones where there has been data from the early studies suggesting that there is benefit, and that benefit may be more with the two drugs than the single drug itself. It's earlier on, so whether this will become an option for patients with myelofibrosis, the trials are very important to demonstrate, but it has made an important impact for individuals with myeloma. So we're hopeful that it'll be helpful in this group of patients as well.
It's great to see when we borrow from different areas of research and clinic, right? It's a great example. So let's move on to navitoclax and JAK inhibitor.
So navitoclax is a medicine. Again, all of these have a theme that they are working in a way different than JAK inhibitors, but potentially in a complementary way. And this one is looking both as kind of that add-on strategy. So they're on ruxolitinib, partial response, and you add another drug in, or as a combination in newly diagnosed patients or on its own in individuals that have failed JAK inhibition. So look at a kind of all three groups. This works against a process within cells that is called apoptosis, a process where cells normally have their life cycle, and when they normally cells are born and they die as a natural process. It is a cousin of a drug that's approved for acute leukemia called venetoclax. And in studies with myelofibrosis, navitoclax has shown real activity for decreasing spleen symptoms and potentially impacting the disease, and combination potentially to a greater degree than just the use of a JAK inhibitor alone. So we have had patients now on large phase 3 trials for individuals in combination who have been newly diagnosed, as well as other situations. So those data are anticipated with great interest.
Another exciting note on more and better treatments, right? Potentially. Finally, let's talk about pelabresib, and that's a drug very close to my heart and actually my bone marrow. That's the trial that I've been on for more than 3.5 years. I've heard, and again, that's used with the JAK inhibitor, in combination with the JAK inhibitor. I understand the results have been very promising. And in fact, at Weill Cornell, they're calling me the poster child for this study. So I'm very grateful for that. Can you, Dr. Mesa, would you tell us about this trial, the Manifest-2 trial?
So this is probably the furthest along of the combination approaches. And the earlier study, so pelabresib is an inhibitor of another cellular process called BET, B-E-T. And again, without getting too deep in the science, there's reason to believe that it may really have a very complementary role to inhibiting JAK2. And in the early studies, really appeared very promising, as fortunately it has been for yourself, in terms of having an impact, perhaps more than JAK inhibition alone, or in combination when individuals had failed a JAK inhibitor. So we now have phase 3 trials of patients newly diagnosed or who are JAK inhibitor naive, receiving this combination versus ruxolitinib alone, and are looking for that information to a great degree, with great interest, to see what really is the net benefit of using the two drugs alone. Are the responses we see more profound for the disease? Do they last longer? Are patients better off? We always weigh that against, are there any downsides to being on the two drugs kind of versus the one drug? But for patients, you can think that there's multiple of these combinations that are being tested in parallel. It's possible that multiple of them may be beneficial. It's possible that multiple of them could become FDA approved. It may take further time for us to identify, if you're a patient, which of the combinations is a better fit for you. These trials are not necessarily designed to answer that itself. They're really designed to answer the first question: are they better than a JAK inhibitor alone? And then downstream, we'll have a better understanding based on specific patient features or other aspects of their health, whether one of these combinations may be a better choice for one patient versus the other.
Right. So, Dr. Fleischman, what should patients be asking their doctors to understand if one of these combination therapies might be best for them?
So I think entering into a clinical trial is really a personal decision for the patient, and really does deserve some deep thought. Um, I guess there's many reasons why somebody may want to do a combination therapy. Number one, potentially their current therapies aren't working. Number two, which I think is is a very important point, that clinical trials are not necessarily only supposed to be for the benefit of the patient themselves, but by participating in a clinical trial, the patient themselves is increasing our knowledge of whether specific combinations work, what's appropriate dosing, what are side effects, such that you're helping other patients that will come after you. So I just want to emphasize that clinical trials are not only for the patient themselves, but they're helping the community of MPN patients that will come after them to really identify what the best treatments are for specific myelofibrosis patients. But there can be many reasons to enter into a clinical trial. I want to emphasize it's probably not only just because your current therapy isn't working, or that you want something quote new. It's to help other people.
Right, which is really a good reminder. So you mentioned, both of you, that we go into clinical trials often because we were on Jakafi or another treatment and it wasn't effective, or it caused complications or side effects that were serious, and it needed to be discontinued, or maybe it worked for some time and then stopped. Can you add a little bit more to that, Dr. Fleischman, about aiming to introduce that non-JAK inhibitor treatment?
So there can, and in terms of, JAK inhibitors are very good in terms of reducing inflammation, and reducing spleen size, and in some patients can work very well for a period of time. Then patients can get, I'm not sure if the appropriate word is quote resistance, because the resistance with JAK inhibitors is very different than what we think about resistance with other cancers. We know that people on JAK inhibitors don't develop new mutations that make them quote resistant to the JAK inhibitor. They just start to not work as well. So that would be one reason to then add on, basically targeting different pathways than simply JAK2 in the disease. And because myelofibrosis is a very heterogeneous, or each patient is very different. Each patient may have different mutations. They may have their JAK2 or their calreticulin or their MPL, but some patients will have additional mutations that make them look a little bit different than other myelofibrosis patients. So really trying to target multiple pathways. And as Dr. Mesa had mentioned, this is a very common technique in other cancers, because cancers are pretty smart, that if you target one, they're going to find a way to get themselves around that medicine that you're giving them to divert. They're quite ingenious and able to grow even despite our single treatments. I think it's really, each myelofibrosis patient is very different. So identifying what the appropriate second agent would be is really on a case-by-case basis.
Right. And I think it's important to note that, at least what's exciting for me is to see that we're more forward thinking in our endpoints of clinical trials. So we're looking more at survival and not just symptom relief, which maybe we'll talk a little bit about in a few minutes. But of course, all of the clinical trials that we've talked about so far are exploring new drug treatments. And I just want to note that there are also trials that look at lifestyle issues like exercise or benefits of yoga and meditation. So for example, Dr. Fleischman is renowned for her work studying inflammation and diet. In fact, she and her collaborators recently published results of a clinical trial that tested the feasibility of the Mediterranean diet for MPN patients. And for those of us living with an MPN, anything we can do ourselves to potentially control our symptoms is very welcome. And in fact, it helps us feel in control of our own blood disorder, which even if it's only a little bit, is important. Moving on to Dr. Mesa, let's move on to an area of treatment that the MPN community is very excited about exploring. And that is a novel therapy that is targeting calreticulin, the CalR mutation. And that's one of the most common drivers of essential thrombocythemia and myelofibrosis. People are calling this a potential vaccine. What can you tell us about this that explains it best?
Sure. So about a third to a little more, or a third or more of patients with myelofibrosis have a mutation in the protein called calreticulin. Now, why this is a little different than the JAK2 or the MPL is that the calreticulin might be on the surface of the affected cells, and that we may be able to target the abnormal calreticulin in a way that is specific. Part of the challenge that we have with medicines against blood cancers or cancers are there ways that we can deliver medicines solely to the cells that are affected with the disease and not harm normal cells. And in the bone marrow, that's a really particularly important point. So there has been great interest to see, can we target calreticulin in a specific way? There's even been already a vaccine trial that was done in Europe in its infancy against calreticulin. So you can think that there's a theme of multiple different approaches being developed, both with cellular-based therapies such as CAR T or vaccines, or this medication that is creating great interest but has not yet started in human trials, a monoclonal antibody against calreticulin that is from Incyte. So that trial is generating great interest, and in the laboratory appears to be a very promising medicine. So we're both very hopeful, but we also recognize that until we've started treating patients, we never know how good a fit it's going to be, or is there going to be an unexpected side effect, or will it have the benefit that we hope that it has? But I think as a theme, it's a very, very exciting theme. I certainly hope that this medication is successful. But even if it is not, I suspect there will be others behind it that hopefully will be. But I'm very hopeful for this one. And like anything, we learn from trials whether they end up really being a home run or not. So I think this theme of, again, us trying to selectively target the cells involved is really key.
So, Melissa, let's move on to trial knowledge number 3. People who decide that they want to explore clinical trials, what can they do to find one for themselves? So we know that the clinicaltrials.gov site isn't the most user-friendly, but it did recently receive a makeover. That's why the LLS Clinical Trial Support Center is in existence and is so important. So tell us a little about that.
Yeah, although clinicaltrials.gov is updating the format of their website, I agree it isn't the most user-friendly and it can be difficult to use. A bit of background about the website is that clinicaltrials.gov is a searchable registry and database of clinical trials conducted in the United States and around the world. So patients can go online and check it out, but it can be overwhelming, and that's where the patient's healthcare team and the CTSC at LLS can come into play. Now, patients can talk to their doctors and learn more about clinical trials that are done at their home institution or outside of it. The more you ask and open up the lines of communication with your team about potential treatment options, the more you learn. So this can help you better understand what options are available to you and just feel more comfortable moving forward with a treatment plan. And LLS created the Clinical Trial Support Center, or CTSC, exactly for this reason. It's really to arm patients with information to take back to their healthcare team. And the CTSC provides a free service to patients. It usually takes under 5 minutes to fill out a form online. Don't get overwhelmed. If you're worried that you haven't filled out enough information, please submit it anyways. And we reach out to patients within 1 to 2 business days. Typically, it is the same business day once we receive that referral. And when you connect with one of the CTSC nurses, you can expect really a teammate that will join you on your cancer journey. And then we search for trials and go through each one individually, which is a little bit different than other online services. We just take more of an individualized approach, and we only send trials to patients that they're likely eligible for. We send the results to the patient and then encourage them to take it back to their doctors and discuss the results. the clinical trial landscape is pretty complicated, and the CTSC nurse navigators are really here to break down the barriers to clinical trials that patients face to help them make those informed decisions. Again, we're just here to help and welcome any patient referrals.
Dr. Mesa, anemia is very common in myelofibrosis, as we know, and many people need regular transfusions. So this isn't something that's likely to go unnoticed, right? There can be severe associated fatigue, and MF patients will have regular blood tests. So in theory, it should be seen and diagnosed at an early onset, right? So tell us about some of the new hopeful treatment options for MF patients who do suffer from anemia.
Myelofibrosis anemia has multiple different aspects. There can be baseline anemia because the bone marrow is not producing enough red blood cells, or there can be other contributors. If they've had baseline iron deficiency that contributes to that, or if the spleen is very enlarged, it can hold on to many red blood cells. Historically, we've had a range of options, but none of them have been overly dramatic in terms of their impact, but they can help. Injections such as the erythropoietin stimulating agents, medicines like erythropoietin, the androgens, danazol, androgens, things like testosterone do help to produce red blood cells in both men and women, so that is important. There are medicines that are in development. Luspatercept, a medicine that can help with anemia, that's approved in a couple different types of anemia and is currently in phase 3 clinical trials for patients with myelofibrosis. And then most recently approved just now in September 2023, momelotinib, which is a JAK inhibitor, but that can also help to improve anemia. And we look for that medicine to improve both spleen symptoms and anemia. Now, as we think about anemia, there are the JAK inhibitors that can have impact in spleen and symptoms, but they may either, one, worsen baseline anemia. So you came in anemic, but as a side effect, you become a little bit more anemic. Or two, they do not improve anemia. So both things can be present. So momelotinib, I think, is an important advance. And I hope that as we see other combination therapies, we may see that kind of broader improvement in spleen symptoms and anemia. There's the question yet also to be answered, with some of these combinations, should momelotinib or those agents that are more helpful with anemia, perhaps even pacritinib, be that JAK inhibitor to be used with these other medications in combination. That is still kind of to be tested. But I think some real progress in anemia and improving anemia can clearly have a benefit, both in terms of, I think, patients' quality of life, their ability to really have enough energy to be able to do their activities of daily living or the things that they really enjoy, as well as it's probably easier on the body, the heart, the lungs, the organs, if they have less anemia that they are struggling under.
One question that's come in is about symptom control while being on a treatment or a therapy. Dr. Fleischman, what I find very exciting in today's clinical trials is that we're moving beyond just symptom management, right? And moving more toward progression-free survival or thriving, living longer with a high quality of life. So when evaluating clinical trials, it's important to understand what the goal of the study is. Where do you think we are with this?
So that's a very important point. So for a clinical trial, you need to have an endpoint, a defined thing that you're going to test. Ideally, something that you anticipate that your drug of interest is going to achieve better than the comparator. And classically in myelofibrosis, we've focused on spleen volume reduction and symptom burden because those are two things that we can quantify and expect to see a change in a short period of time. And although spleen size reduction and symptom burden are extremely important for myelofibrosis patients, it just doesn't capture the whole picture of myelofibrosis. The endpoint of survival obviously is extremely important to myelofibrosis patients, extremely important to everybody, their survival. But because in general, myelofibrosis patients, thank God, can live a long time, and many times is not really a feasible outcome for clinical trials. So one area that we're really intensely working on is trying to identify surrogates for survival, or something that we can capture with data amenable to a clinical trial that really will be a marker for disease impact. There are some clinical trials, such as the imetelstat clinical trial, in which the survival is the actual endpoint, which I think is a quite unique and forward-thinking endpoint. But still, one of the key areas of need in myelofibrosis is identifying markers that can be used in clinical trials that really indicate a significant impact on the disease that's going beyond just reducing spleen size and reducing symptoms.
Yeah, we're definitely getting into a very exciting time that will make such a difference therapeutically once we have those answers, right? The next question we got from a patient is, when is the best time to get a stem cell transplant? And I know there isn't a black and white answer, but Dr. Fleischman, how do you answer this common question?
So that is another $1 million question in myelofibrosis. And I think probably is the most difficult decision for a myelofibrosis patient, as well as for the physician. So as we know, a bone marrow transplant at this point in time is the only curative option for patients with myelofibrosis. And although a transplant, you may say, well, if it's curative, why doesn't everybody just get a transplant? Transplants themselves can be quite risky. I think the media may miscommunicate transplants. You always see on the news that, somebody's looking for a donor, and the communication may be that the only problem with transplants is you can't find a donor. That's not necessarily the case. A transplant itself is an extremely risky procedure that can lead to death, can lead to some significant side effects. So we don't want to give somebody with myelofibrosis a transplant if the chances are that transplant's going to make them sicker or potentially lead to their death earlier than would be the case if they didn't have a transplant and just treated their myelofibrosis through other means. So the ideal time to transplant is when you get clues with this myelofibrosis patient that if you do not, with standard treatments, they are very likely going to have an extremely bad outcome or will have an outcome that will lead to their death very quickly. Then that's the time when going forward with a transplant is worth the significant risk of that transplant.
So the balance between whether we have a patient undergo a stem cell transplant or a medical treatment is always a balance, as they have very different dynamics. A stem cell transplant can potentially be curative, but can come with significant risk, including upfront risk. The benefits for the medication, depend on many things. How much benefit, how long is that benefit, and the impact for the patient. I would certainly view it as a success that if we are able to have medicines that are sufficiently impactful, that it leads us to either be able to skip a bone marrow transplant or to delay it further. We certainly have precedent for this in other areas. I think for the current time with our current medicines, we are not changing our decisions for transplant, but increasingly, almost all the patients that go to transplant have at least one or more of the JAK inhibitors ahead of time. And the data would suggest that the outcomes with transplant are probably better, in part because of JAK inhibitors, but also in part because of improvements in the processes, the antibiotics, the other medications, and the expertise of our colleagues that run transplant centers.
So we have another patient question. Carlos asks, when should a patient ask about clinical trials, which is a common question. So to both of you doctors, how and when do you introduce the idea of considering a clinical trial to your patients?
So, clinical trials may exist in any aspect of the disease, from diagnosis to initial treatment to a treatment downstream. So, I think it's always a fair question for patients to ask: is there a clinical trial that may be appropriate for me? It is not limited to just kind of one segment of the disease. Clinical trials are how we make progress. They are highly regulated and always have the needs of the patient really front and center, so that at a minimum, a patient is always getting the option that is at least as good as the standard of care. So I think it's a fair question to ask really at any point along the way, whether that isn't in consideration. Truly, all the options we have only been possible because of patients' willingness to participate in clinical trials.
And Dr. Fleischman, how do you introduce the idea of considering a clinical trial to your patients?
Well, when I approach a new patient, when we talk about treatments, I'll always talk about standard of care treatments first and giving people their options, pros and cons of each of the standard treatments. So then, after going over standard treatments, I first talk about um, clinical trials that I think either at my own university or elsewhere that I think would be appropriate for the patient. Obviously, what I would do first is if there was something specific that I thought the patient would be ideal for, would talk about that clinical trial first. But because I want to give the patient all of the information, then I would talk about other clinical trials that the person may be eligible for, and I would give them reasons why it might be a good idea, but then also give them reasons why, if I don't think that clinical trial would be really ideal for them, give them specific reasons why. Um, also, talk about other clinical trials and would say, well, you may have heard about this clinical trial, but because of this aspect of your myelofibrosis, you are not eligible for that clinical trial. So I think it's important to first discuss standard of care. Then my next step is focus on clinical trials that I think would be great for that patient, clinical trials that may be okay for that patient, but is really up to the patient, and then also disclose other clinical trials and tell them why they are not eligible, or I think they wouldn't be a good candidate for that clinical trial. But that I have the benefit that I can spend a lot of time with patients. I highly recommend second opinions or even third opinions. Um, Sometimes patients feel bad if they think that going for a second opinion, their primary oncologist may think that they are not happy with you know, their approach and want to see whether somebody else has a different approach. That is not the case. As physicians, we are happy to have another set of eyes look at the patient, another person's thoughts. There's in no way, that you feel that you're hurting your physician's feelings by seeking out a second opinion. It would be, I'm sure the physician would be extremely helpful to get some advice, or having support saying, yes, what you're doing is exactly what I would do too. So second opinions, third opinions are great. Even if it's just, I want to learn a little bit more about my disease. I'm happy with my treatment now, but I just want to know a little bit more, get somebody else's view, learn about my future, what might be the options in the future if this happens or that happens. So I highly recommend a second opinion or even a third opinion.
And we're moving on to our final trial knowledge bit, number 4, and that's about the process of staying in a clinical trial. So we've covered the why and how of getting into a clinical trial, but what are the top 3 things that you do at LLS to help people stay in a trial?
Oh, absolutely. I talked briefly a little bit about this in the intake call earlier and how we learn about each patient. And I think that taking that personal approach and extra time with the patient to learn what their treatment goals are, what their physician's goals are, and what they're looking for in a trial really helps with trial retention. And so, barriers, I feel like, is the first challenge. The nurse navigators are proactive during that conversations with breaking down the barriers that patients might face. So, are these barriers financial? Will they have to travel for a trial if we find one that they're interested in? And really, our solution to these issues is to find out if a trial offers financial assistance in addition to what we may offer at LLS. We email trial coordinators and principal investigators all the time, and we can inquire about the treatment schedule. So, how many visits the patient may expect? Can they get labs at their home institution? And this is also dependent on what phase the trial is in. This may not be possible for some of those phase 1 trials, but more possible for phase 3 or phase 2 trials. Or can any of the long-term follow-up visits be virtual? And our solution in the CTSC is to help break down the intimidating medical language or trial jargon. We try to use the simplest explanations, and if patients want more in-depth or complex information, we can definitely adjust and provide that as well. And we always check on a patient's understanding. When we've explained something or provided information, we may ask the patient to repeat back what they understood and listen as they walk through that process with us. The more they understand, I feel like they're more comfortable when they feel like they're making that decision for them. So I did want to just touch base on different ways of how to contact us at LLS. So our main hub is really our information resource center. Those are our information resource specialists, they're nurses and they're social workers. And so you can call us at our 1-800 number Monday through Friday, 9 a.m. to 9 p.m. Eastern Standard Time. If it's easier for you, we also have a chat option where you can do a live chat online. We also have an email address. And if for some reason you reach out to us outside of our business hours, you can always leave a message 24/7 and we'll give you a call back.
Great to have that information. Thank you. So to close today, would you each tell us what your top takeaway is? If you could leave people with just one message, what would that be, Dr. Mesa?
I would leave them with a message of hope. We have made a tremendous amount of impact, much greater understanding of the biology of the disease, the genetic mutations, why people progress, and now we are building on a base of very good medicines that have made an impact with the JAK inhibitors, but I think to a new era of multiple different approaches. I would heavily encourage patients to consider clinical trials where appropriate. Clinical trials will build on the base of these medications to try to drive progress further and further. We need your help, and together we will continue to improve the therapy of diseases like myelofibrosis.
So I would say we're in a very exciting time for myelofibrosis. Just in the past few years, we've moved from a single FDA-approved JAK inhibitor to now 4 JAK inhibitors. So in real time now, we can personalize FDA-approved drugs, JAK inhibitors, for each myelofibrosis patient. That's real time. But then looking towards the future, there are a lot of opportunities for combination treatments that are moving forward in clinical trials, as well as going beyond JAK inhibitors, trying to identify other key pathways to target in myelofibrosis to lead to real tangible improvements and outcomes for myelofibrosis patients.
It's difficult, but I'll try to summarize it. In the CTSC, we educate, support, and really empower myelofibrosis patients as well as other blood cancer patients to be active participants in and have control over their treatment decisions with their healthcare team. The Leukemia and Lymphoma Society wants to make a difference in patients' lives through research, advocacy, education, support, and financial assistance. And we want to see a future without blood cancers. We have a lot of free information for patients, caregivers, and healthcare providers to check out. And remember, we're just a phone call away. And we are here in the CTSC to help make clinical trials less overwhelming for patients and to help healthcare providers.
We have covered an awful lot of information and invaluable insight from our experts today. I know I speak for people living with ET, PV, and MF, their loved ones and care partners, when I offer our very sincere gratitude to you all for everything you do for our MPN community. Thank you.
Thank you so much, Ruth. Always appreciate the way you bridge the conversation for us. Also, thanks so much to Doctors Mesa and Fleischman for the work you both do, both in clinic and in research to help patients and families who are trying to navigate a myelofibrosis diagnosis and treatment and all the decisions that come in between. And also to our LLS clinical trial nurse, Melissa Melendez, for being there day to day, helping people overwhelmed by this whole topic of clinical trials. And thank you to all of you for tuning in. We really hope that the biggest, most important thing, you walk away with a greater understanding of clinical trials in myelofibrosis. And remember, we really, really want to hear from you. A survey is going to come up right after this box closes to get your feedback, and that will automatically enter you into a raffle for a couple of our $50 Amazon gift cards. Thank you so much. We hope to see you at a future VLLS and the Patient Story program. I'm Stephanie Trong with the Patient Story. Take good care.